Hi y'all, today I'm going to go over a female pelvic anatomy and gynecologic pathology review. I'm going to move through this in basically the order of the female anatomy from external to internal. I'll start by going over some common vulvar pathologies, then I'll talk about vaginal cancer, cervical cancer, then I'll move through a basic female pelvic anatomy review with a focus on various gynecologic emergencies that are going to make you need to take somebody to the OR. Then I'm going to quickly wrap up with a review of pelvic organ prolapse and go through the different types of prolapse and the classes that you should be familiar with for the Step 1 exam. First, I'm going to talk about Bartholin cyst. The Bartholin glands sit at the posterior lateral vaginal introitus at 4 and 8 o'clock, and they provide vaginal lubrication. A Bartholin cyst, though, happens when that duct gets obstructed and the fluid backs up behind it. It results in painless swelling that's a cyst, but then if it's painful, erythematous, and tender, you're probably dealing with a Bartholin abscess. Most commonly, this is going to be polymicrobial, but if it's one organism and they ask you on an exam, it's probably E. coli. You need to remember that you treat a cyst with a ward catheter, and then if you have an abscess, you're going to use incision and drainage and then add the catheter later. Another common condition that you will see in real life and be tested over is lichen sclerosis. This is a chronic inflammatory autoimmune condition of the vulva. Classically, you're going to see thin, white, parchment-like skin. On the exams, it typically really stresses how fragile the skin is, sometimes calling it things like cigarette paper or parchment paper. You can have loss of normal vulvar architecture in this condition, and it can be really painful for patients. A lot of patients will present to you worried about not only how it looks, but that they are having dyspareunia or pain with sex. Something important to remember, both for real life and the sake of your Step 1 exam, is that lichen sclerosis greatly increases your risk for vulvar squamous cell carcinoma. On the other hand, you have lichen simplex chronicus, which is hyperplasia of the squamous epithelium. Often people present with a lot of itching and discomfort, and the skin becomes thick and leathery. So it's kind of the opposite of lichen sclerosis, even though it has a similar name. Okay, now I'm going to talk about the big villain when it comes to all genital tract cancers, and that's HPV. It causes condyloma acuminata, and that's especially the low risk strains of HPV, which are 6 and 11. Those are the ones that lead to genital warts. On the other hand, the high risk strains are 16, 18, 31, and 33. There's some other bad ones, but those are the ones you should know for your exam, and those are really likely to lead to both cervical cancer and vaginal and vulvar cancer. HPV oncogenes that you should know about are E6, which is going to degrade P53, and E7, which inactivates RB. Both of those are important for when the cell is cycling between G1 and S, throwing on the brakes if there's been cellular damage. So what HPV does is that it creates a loss of tumor suppression by activating the oncogenes E6 and E7. Again, I'm throwing this little lichen sclerosis illustration over on the right hand to remind you that also increases your risk for vulvar cancer. It is not the same pathway as HPV. That's why it's over on the other side. So just remember that most of the time when people are getting vulvar cancer, it is related to HPV and progresses down from the cervix, caused by these high risk strains. But you also can be getting vulvar cancer from long-standing lichen sclerosis that's gone untreated. The other wonderful news that you should know about HPV is that now we have a really good vaccine for it. It's called Gardasil. It's a subunit vaccine. It vaccinates against the most common strains of HPV, including a lot of the worst ones. Now we're on Gardasil 9, and it can vaccinate against 9 of the different HPV strains. Kind of a fun fact about Gardasil is that in Australia, they have mandatory Gardasil immunization, and they're going to have herd immunity from HPV by 2030. I wish we could get with the program on that because that would be pretty awesome. We'd have to do less pap smears in the United States. Moving on to vaginal cancer. Primary vaginal squamous cell carcinoma is pretty rare. You're probably also not going to be asked about it on exams just because it is so infrequent. It's usually going to be secondary to cervical squamous cell carcinoma, which you will be asked about on exams and you will see in real life. Something though that the test makers really seem to like is clear cell adenocarcinoma, which is usually secondary to vaginal adenosis, which is the persistence of glandular tissue in the vagina where it shouldn't be. Now, historically, that's linked to DES exposure. You also can get it from Müllerian abnormalities, but that's less common. Okay, and a practice question about another type of vaginal cancer that they like to ask us about on exams. So you have a 4-year-old girl, 5-year-old girl, young girl who presents with a clear polyploid, maybe they'll say it's grape-like mass protruding from her vagina. What do you think that is? So it's going to be a sarcoma botryoides. I think I'm saying that right. It stains positive for Desmond because it's a malignant proliferation of rhabdomyoblast, which are really immature skeletal muscle. Something else to be aware of is where vaginal carcinoma likes to spread in terms of lymph nodes. If it's in the upper 2/3 of the vagina, it's going to spread to the internal iliacs, versus the bottom 1/3 is the inguinal. How I remember this is that it's kind of like a triangle. Iliac is a shorter word, and inguinal is longer, so it's the base of the triangle. That works for me, but inguinal is the base of the vagina versus the internal iliac is the top. Okay, everyone get excited. We're going to talk about the cervix. So the bottom of the cervix is called the ectocervix, and the top of the cervix is called the endocervix, and the area in between the ecto and endocervix is the transformation zone. Normal cervical histology consists of the ectocervix having non-keratinized stratified squamous epithelium, and it'll have glycogen in it. And then the endocervix has a single layer of tall, mucinous columnar epithelium. When you do a pap smear, you sample the region in between them, the transformation zone, because that's the site where most cervical dysplasia arises. Now, what's cervical dysplasia and why are we getting it? The answer is the villain, again, HPV, but this time it's the bad strains, so you really want to watch out for 16, 18, 31, and 33. And that's when you really want to start thinking about pathological cervical histology findings. So low-grade cervical histology, or CIN1, that's just mild dysplasia, and changes are only present in the lower 1/3 of the basal epithelium. Now, high grade is CIN2 and CIN3. CIN2 is moderate dysplasia. It's in the lower 1/3 to the 2/3 of the basal epithelium. CIN3 is severe irreversible dysplasia or squamous carcinoma in situ. The changes are present in more than 2/3 of the basal epithelium, but the basement membrane is still intact. When you get beyond that, it's invasive cervical cancer, and that's invasion beyond the basement membrane of the cervical epithelium. Some other things that you might be asked about the cervix or pap smears is how do you know that you got adequate cells for a pap? You want glandular endocervical cells. If you are getting glandular endocervical cells, that means that you've gotten up into the endocervix and you're there at the transformation zone where you're most likely to catch any dysplastic changes. Something else that comes up a bunch in real life and on test is you're going to see microscopic hemorrhages and dilated capillaries on the cervix. Maybe if the exam people are feeling super nice to us, they're going to call it a strawberry cervix, but that's trichomonas, and you want to treat that with metronidazole. One of the big ways they like to ask about this is they'll say that there was a young woman who had some sort of discharge and she went to her gynecologist and they wrote her a prescription, and then she goes to a party and she drinks some alcohol with her friends and then she gets super duper sick. Why is that? Because you are not supposed to drink when you're on metronidazole. So that's kind of a backwards way that they could ask you about this same pathology. Okay, moving on to the female pelvic structures. I'm going to go through a few different ways that I've seen the questions test on anatomy, because I feel like the whole pelvic basket can be kind of confusing, and it never hurts to relearn this. So the first case study is you have a 50-year-old woman, she comes to you to get a hysterectomy. What structure is most likely to get injured when you're clamping the uterine artery in the surgery? So your options are ovarian artery, ovarian ligaments, pudendal nerve, and the ureter. So if you look at this diagram that I drew over here, you can see that the uterine artery, it jumps right over the ureter. In an anatomy lab, we looked at this. It's a bridge over water is, I think, kind of the classic memory trick. But that's also why ureters can commonly get damaged in a hysterectomy. Another question. So you're in gross anatomy lab, and Dr. H asks a student to identify the ligament that contains the ovarian vessels. What's the name of this ligament? Your options are the round ligament, the uteroovarian ligament, the uterosacral ligament, or the infundopelvic ligament. And the infundopelvic ligament is also known as the suspensory ligament. So the reason that I drew this out, I think it's really important to see that the ovarian artery and vein are encased in that suspensory ligament. And I think that it's really tempting to hear something like uteroovarian ligament and be like, oh, that sounds like, the ovaries would be supplied through something that has the name uteroovarian ligament. But remember that it is the suspensory ligament of the ovaries that carries the ovarian artery and vein. Importantly, if you, in real life or in a question, have a patient that has suspected ovarian torsion, that's what's going to be getting torsed. Next question. There's a 70-year-old woman who smoked for the past 50 years. She comes to the ED following 1 hour of severe abdominal pain. She has a ruptured abdominal aortic aneurysm. During surgery, there's an artery that branches off of the aorta just below the renal arteries. It's damaged. And what structure will now have impaired arterial supply? Your options are the uterus, the cervix, the vagina, or the ovaries. So really the reason I put this here is just to go through and remind everybody of where all of these structures are getting their blood supply from. So the abdominal aorta splits down into the iliacs, we know that, but off of the abdominal aorta is where the ovarian arteries come. And then further down, off of the internal iliac artery is where the uterine artery and the vaginal arteries come from. So the correct answer in this case would actually be that the structure that's having the damaged arterial supply is the ovaries, because they're having to clamp the abdominal aorta close to where the ovarian supply is. Okay, now we're gonna put it all together. You have a 27-year-old who's never been pregnant. She has a history of endometriosis and PCOS, and she shows up to the emergency department with a 1 hour history of severe abdominal pain and nausea. I do know how to spell nausea, I just really messed up and I wasn't going to go back and fix it for this. Doppler flow shows that she has an enlarged edematous left ovary, and there's no blood flow. So first I want you to think about what ligament is torsed. I went over this a second ago, but that's going to be the suspensory ligament of the ovary because that's where the ovarian artery and vein are encased. That's what's twisting. What structure is at greatest risk of injury when you're going in for the operation to hopefully untwist the suspensory ligament? That's going to be the ureters, and you can look here, the ureter runs right next to that ligament, and especially when you're having kind of gnarly torsion with a big cyst or something, it might be caught up in your surgical field. And I also want you to think about what increased this patient's risk of having an ovarian torsion. It's probably because she has PCOS, or maybe an endometrioma, but whatever it is, there's some large mass or cyst that is causing that ovary to turn back on itself. And one of the ways that you might see this talked about on radiology is it's a whirlpool sign on imaging. And just because you still have Doppler flow in the arterial supply does not mean this is not a surgical emergency. Venous flow is what goes first, and there's like venous congestion that can cause this, so just be on the lookout for that. Now we're going to zoom out a little bit and talk about the big structural support of the female pelvis. Thing number one that you need to remember is that the levator ani muscles are what is holding everything together. And they have some natural anatomic defects in them, they're not even really defects, but they're structural defects. And that's the vagina, the urethral opening, and the rectum. And because these three spaces have more give than those really tough, strong muscles that are holding the pelvic floor up, they're the three places that pelvic organ prolapse typically happens. So what are some risk factors for pelvic organ prolapse? Basically anything that's going to cause stress to your pelvic floor. Unfortunately, the more kids you have, the more likely you are to have this. Vaginal births also increase your risk for pelvic organ prolapse compared to C-sections. obesity, because that's putting a lot of downward pressure and also higher intra-abdominal pressure. Connective tissue disorders, which makes sense, anything that's going to loosen up those muscles or maybe have less muscular tension, and then chronic constipation. So if you didn't already feel a need to eat a immense amount of fiber after studying GI, let this be your reason number two. So there's a couple different types of pelvic organ prolapse. For the purposes of step one, they really ask about this as a way to test your anatomy knowledge, or at least from the questions I've seen. So the first thing, just look on the top left-hand corner. That's going to be what your normal anatomy looks like. In uterine prolapse, the uterus descends. This is usually a loss of integrity in the uterosacral ligament, and it's a ligament failure. You also can have a rectocele or a cystocele. So a rectocele is when there's a weakness in the posterior wall or a rectovaginal fascia defect, and you can have the rectum either falling through into the vaginal vault or kind of at the end of the vagina. Then you also can have a cystocele, which is where the bladder is pushing into the anterior vaginal wall, and this is weakness in the pubocervical fascia. An enterocele is when the small bowel is herniating into the upper posterior vagina. Risk factors for all of these are what I've mentioned before, but aging also can increase your risk for this, and it's believed that's because of estrogen loss, which makes a lot of sense, right? Because estrogen is essential for maintaining the strength, elasticity, and the thickness of all of those pelvic floor muscles and structures and connective tissue. And when estrogen levels drop later in life, these supportive structures weaken, become less resilient, and they cause the pelvic organs to lose some of their support and shift out of their original place. And so this is why in a lot of Urogyn practices, you're going to be mostly dealing with a lot of postmenopausal women, often women that have had lots of kids, or maybe even people that have jobs that require them to be doing a lot of heavy lifting. Anything that, again, is increasing that stress on the pelvic floor can cause problems later in life. Okay, two final questions. First is you have a 33-year-old, she's a G5, P5. She comes to you complaining of a vaginal mass and urinary incontinence. What's the ligament that's lost integrity that's causing her symptoms? So the vaginal mass combined with urinary incontinence, and after you do your exam, you realize that she's maybe having uterine prolapse. So the uterus is falling down into the vagina. What would be causing that? If you can think back to that picture I just showed you a second ago of the whole pelvic floor, the ligament that's pulling the uterus back and keeping it taut is the uterosacral ligament. So that's what she's having trouble with. That's causing her incontinence. And then I'll give you one other quick case. There's a 49-year-old G6 P4 with all vaginal deliveries who presents with involuntary urinary leakage. It happens when she laughs, when she sneezes, when she lifts her kids. She's obese and she has a history of constipation. Again, everybody eat your fiber. But what's going on with her? So it kind of sounds like she maybe has a cystocele or maybe a urethrocoele. But what you also can think about is what's conservative management for this. So her OB-GYN recommends that she start doing Kegel exercises. And what muscles is her OB-GYN trying to get her to strengthen in her pelvic floor? That's right, the levator ani muscles. Fantastic. Everyone's going to do great on the exam. Good luck to all.